How are you doing this
Hi
afternoon?
there, Dr. Brown here. I've got my excellent team. I got Bailey, my favorite rep, Ryan, Christy, my nurse, Patrick, my nurse. We got Todd over there, and this patient is a 71-year-old male, ischemic cardiomyopathy, diabetes, hypertension, dyslipidemia, and severe occlusive peripheral vascular disease with a history of tobacco abuse, who came in with class 4 symptoms, rest pain, ABIs in the low 0.3s. He was found to have an occluded left CFA and SFA and had a prior failed FEMPOP bypass. We opened that up retrograde a couple of weeks ago, and he's already got stents kind of all over his iliacs, and it's real calcified and tortuous. But today we're coming back to treat a bifurcation of the distal CFA on the right into the SFA. It's kind of a focal, extremely calcific lesion. And then we're unsure how involved the DFA is, but we were able to J our wire in that was used to get the sheath in place. So I'm hopeful that that's going to look fine after this, but we're prepared. We're going to wire it when we drug coat balloons. So we started the case. I will show you that picture, our first CO2 image. There we go. So you can see complex, severely calcific distal CFA lesion. Again, surgical turn down, who's got flow into both the profunda and the SFA, which obviously we're going to want to maintain. So we were able to wire the vessel with a Sahi Mongo, and then we exchanged with the Trailblazer for a spider filter wire that we have down in the popliteal artery after that. So we've used a Hawk LX directional atherectomy device, and we've done maybe 6 or 8 cuts so far. We're about to do a couple more. Then we're going to come out, take a picture, and then we're going to wire the profunda, and then we're going to use a drug-coated balloon. We've picked a 7x60 Medtronic drug-coated balloon to treat the CFA and proximal SFA. You can see there's some post-stenotic dilatation in that picture there. That SFA actually measures about 8, but just in that section there. So we're going to go live. This is the Hawk LX. Can you go on for me, Bailey? So in the calcium, I like to go real slow, let it kind of sit on the lesion, work its way through. You definitely want to have distal protection because these calcific crumbs don't fit so nicely into the Hawk. They can break off, chip off, go downstream. Off. On. After this pass, I'm going to take an additional angiogram. All right, off. All right, we're going to pull the device out and take a picture for everybody. You're on CO2? Okay. I think that's looking quite a bit better. Flows better in both. To contrast that, we can go ahead and take a small contrast image, put it on DSA for me. Just got to clear the catheter. So I think that's looking a lot better than where we started. So I'm working on a Shimatsu system. They got great CO2 images. They also have this thing called RSM. If we have a minute, I'll show you a run of that we did earlier. This case, you know, I was wondering what sort of case to pick, and I sure picked a doozy. I'll tell you what, we had a time getting up and over. We got access, had a real tough time getting an Asahi cross lead down, 035. We ultimately were able to and had to spin our microcatheter, the Trailblazers, to get it down in the deep femoral, and then we had exchanged for the nitrix wire. It was still very challenging. And so our sheath right now is up in the kind of proximal external iliac. All right, here we go. So balloon seems to be expanding well, 12. Okay, down. Flora, save that for me. All right, so we'll take a picture and see how the deep femoral looks after doing that. Put it on CO2 imaging for me. All right, flow's maintained in the deep femoral. We'll go ahead and get our drug-coated balloon in there. Now again, that measured 8 in that proximal dilated portion of the SFA. if it doesn't look the way we want after using the 760 drug-coated balloon, we could certainly take a non-drug-coated balloon in there. That's 8 millimeter. See how it looks. Show my live image here. We're gonna play the RSM run. Let me start it over real quick. Well, so I thought. I'm gonna have to just wait for it to finish. I'll tell you a little about RSM and why I like it. Now, again, I was trying to not use a lot of contrast here, but the cool thing is you get essentially a road map and a DSA-like image with just kind of one run down the leg using 10 millimeters of contrast. So here's the start. Just kind of watching it go down. I'm just panning by hand. Obviously, I pulled the spider back. It was often a geniculate there. You guys show the IVUS image, please. Yep, go ahead and run it. I'll tell you when to stop it. I would not stent that. I would leave that be. All right. You can turn off. I don't know if we quite got the 30% residual lumen, but we do have a lumen.
Yeah, nice result, and I think I would agree with you in this space. The last thing you want to do is force yourself to make a decision whether you have to bail out stent or something like that. So nice result.
Thank you. All right, I'm going to get the catheter out and we'll close up shop here.
All right, thanks a lot. Have a great day.